Good afternoon, teacher. I'm going to talk about the Canagliflozin and renal outcomes in type 2 diabetes and nephropathy. The definition. Type 2 diabetes mellitus is the leading cause of kidney failure worldwide, but few effective long-term treatments are available. In cardiovascular trials of inhibitor of sodium and glucose contrast two exploratory results have suggested that such drugs may improve renal outcomes in patients with type 2 diabetes. Application in medicine. Develop new treatments that can prevent or delay the progression of chronic kidney disease. The SGLT2 are drugs that improve glycemic control in patients with diabetes mellitus type 2. At the moment, they are marketed: empagliflozin, canagliflozin, and dapagliflozin.
The Credence trial was a trial that was designed to study canagliflozin, which is a drug that people with diabetes take to lower the blood sugar. And we wanted to evaluate if canagliflozin improved kidney function in people who have type 2 diabetes and have kidney disease with it. Credence showed that canagliflozin reduced the progression to kidney failure by 30% compared to placebo. Importantly, it also reduced cardiac death and hospitalizations for heart failure by 31%. This finding is really important because it is the first drug in 20 years that shows that you can improve kidney outcomes and the progression to renal failure or kidney failure and hemodialysis in people with type 2 diabetes.
The pros and cons. The pros can reduce a kidney disease. The cons, the myocardial infarct, stroke, hospitalization for heart failure, and death.
What this means is it's a total game changer for the management of diabetes. It's a game changer for the outcomes of our patients with diabetes. They usually have hypertension, dyslipidemia, chronic kidney disease, goes hand in hand with diabetes and with the reason why these patients die, which is cardiovascular disease. So to have this indication, to have this class of drugs, it's just a great time to have diabetes, honestly, if you're going to have it.
Applies in Ecuador. At that time, 4,100 patients undergone randomization with a median follow-up of the 2.62 years. The relative risk of the primary outcome was 30% lower in the canagliflozin groups than in the placebo groups, with the event rates at 43.2 and 61.2 per 1,000 patient years, respectively. A conclusion: in patients with type 2 diabetes and kidney disease, the risk of the kidney failure and cardiovascular events was lower in the canagliflozin groups than in the placebo groups, and the median follow-up of 2.62 years.
And welcome to our program. So let's start with a section on managing diabetes with comorbid cardiovascular disease. And we'll start with a case, as we like to do, and the case will be a backdrop of a few cases during this session.
Yeah, so I have a few concerns, in fact, Dan, about her case. So she's a 68-year-old with A1C of 6.6% on 3 agents, including an SU. So my first concern is hypoglycemic events in someone who's older. Now, if we look at DECLARE, as you may know, had 2 co-primary endpoints. One of them was MACE, which I show you here. MACE in DECLARE was neutral. There was 7% reduction in events with DAPA compared to placebo. The p-value was not significant. And in VERTIS trial, MACE was also neutral.
So here I'm going to share the data now for the same trials that Serge nicely took us through for EMPA-REG outcomes and CANVAS and DECLARE TIMI 58, but now looking at a different outcome, at CV death and hospitalization for heart failure. The reductions in CV death and hospitalization for heart failure. And if you look at the magnitude of these, you can see they range from 20 to 30% reduction. So really substantial reductions in that risk. It's a great question. I would say as a clinical trialist, we typically use BNP to make sure as much as we can that we're getting the real McCoy.
And if we come back to the slide about how SGLT2 works, the SGLT2 inhibitors, they primarily work at the proximal tubule and primarily only at the S1 and S2 segment of the proximal tubule. Now, the field really changed quite a bit about 3 or 4 years ago with the report of the empagliflozin and the canagliflozin studies. So here we see the CREDENCE study, which looked primarily at patients with kidney disease and found that there was a marked benefit in reducing composite endpoint of development of end-stage renal disease, doubling of serum creatinine, or renal death, meaning patients died before they start dialysis, or cardiovascular